I'm Andrew Murata, host of the Education, Leadership, and Beyond podcast, a part of the Education Podcast Network, just like the show you are listening to now. Shows on the network are individually owned and opinions expressed may not reflect others. Find other interesting education podcasts at edupodcastnetwork.com.
Hey, welcome back. Steve here, and today I'm talking with Colonel William Wall and Dr. Tim Moss, and they're sharing with us their book for assisting combat veterans and their families. It's called Complexities and Challenges, Clinical Perspectives in Combat Veteran Treatment and the Unique Needs of Military and Veteran Families. What an awesome, powerful book. It'll provide combat veterans and their family support for addressing those so many challenges they may be facing as they return to the civilian world. You're going to learn so very much today. Thanks for listening. And by the way, before you go, it'd be so cool if you shared Teaching Learning Leading K12 with a friend, a family member, a neighbor, a colleague. What do you think? Could you do that for me? That'd be so cool. Thanks for listening. Thanks for sharing. Enjoy the show.
It's the Education Podcast, your favorite show, with lots of groovy guests and they share what they know. So crank it up to 10 and let your neighbors know that here's another show with Dr. Steve Milletto. Teaching, Learning, Leading K12. Teaching, Learning, Leading K12. Teaching, Learning, Leading K12. With Dr. Steve Milletto.
Lieutenant Colonel retired William Wall is a combat veteran and CEO for the Center for Life Stress and Psychotherapy. He is a 30-year veteran of the Air Force and Army and an internationally recognized leader in the field of disaster and military-related clinical trauma. During his Air Force career, he served as the Mental Health Deputy Flight Commander at Wright-Patterson Air Force Base and the Chief of Behavioral Health for Air Force Materiel Command. He was deployed in 2004 to 2005 as a Combat Stress Team Commander for Operation Iraqi Freedom and learned firsthand the dynamics of combat stress and its relation to PTSD. He served as Social Work Ambulatory Programs Coordinator and Manager for the Freedom Center, the Dayton VA's Medical Center, Operation Enduring Freedom, and Operation Iraqi Freedom Post-Deployment Clinic from 2007 to 2017. He holds a master's degree from Our Lady of the Lake University and is board-certified licensed clinical social worker trauma therapist. He serves as a mental health team member and former clinical director for the Southwest Ohio Critical Incident Stress Team. He is currently an adjunct instructor at Wright State University and lectures nationally on the subjects of mental health, trauma recovery, organizational leadership, and development. Dr. Timothy Moss is a decorated combat veteran, author, psychotherapist, leadership consultant, motivational speaker, and CEO of Breakthrough Leadership Consulting. He is a veteran of the Air Force and Army and an internationally recognized leader in the field of behavioral health and military-related clinical trauma. During his Air Force career, he served as a senior mental health and family advocacy officer. He served as combat psychotherapist and clinical traumatologist for the Freedom Center, Dayton VA's Medical Center, Operation Enduring Freedom, and Operation Iraqi Freedom Post-Deployment Clinic from 2008 to 2017. Dr. Moss holds a Master of Science degree from the Ivy League Columbia University, New York, and a Doctorate of Counseling from Logos University. He is a fellow in the American College of Healthcare Executives and board-certified expert in traumatic stress. He is the past president and chairman of the board, National Association of Social Workers, Ohio chapter, and served as an adjunct professor at St. Leo University. He is the author of Clear Vision in a Dark Place and Can I Just Have Jesus? He lectures nationally on the subjects of organizational leadership and development, mental health, trauma recovery, spirituality, and community development. We're focused today on their book, Complexities and Challenges, Clinical Perspectives in Combat Veteran Treatment and Unique Needs of Military and Veteran Families. Gentlemen, thanks for joining me today, and say hi to everyone.
Hey, it's a pleasure to be here. Thank you.
It's a pleasure to be here, Stu, and thank you for your service to our country as well.
Absolutely.
Well, thank you both, and thank you both for your service to our country, and I appreciate it. This is awesome talking with you, and so everyone knows, we're now going to refer to a little more informal names. So Dr. Moss is now Tim, and Colonel Wall is now Bill. So we're glad that you guys are with us today. And gentlemen, like we said, this is it's amazing the service that you've given to your country and to your fellow veterans and so forth. And I can't thank you enough for that. And the first thing I want to talk with you about is your decision to serve in the military. Can you talk about, what encouraged you to step forward and raise your right hand?
I'm used to the colonel going first, so I typically come after you.
Did you say you're going to go first?
No, I was going to say, I always defer to you, the colonel,
Okay.
colonel before the captain.
Okay. So kind of what encouraged me to step forward when I think about being so a couple things. I was in college from 1969 to 1973. I went to college at Case Western Reserve University. I was actually an engineering major, which is really kind of odd looking back. But probably one of the biggest motivations was my older brother, Terry, who is a Vietnam vet. And he was drafted. And what was odd was amidst all of the demonstrations going on, it was kind of almost surreal in the sense of, watching this go on and kind of participating. But, I was much more concerned about kind of the idea about skin in the game. My brother's over there. We're hearing about people that are dying and so on and so forth. And then over the course of his tour in Vietnam and my college education, by my sophomore and junior year, by 71, we started hearing about Vietnam vets coming back. And so suddenly in the midst of the demonstrations that were mostly college students, you had veterans that had been in Vietnam, had survived. And really what I started hearing was different things about their experience. And also the lack of mental health services for them. That was kind of a key factor. And I changed my major from engineering to kind of pre-med. I was really a psychology, sociology major, but I was really fascinated with kind of what was going on. Keeping in mind, by the end of Vietnam, we didn't have a diagnosis called PTSD, right? So a lot of the dynamics of what was going on there was really one of the things that kind of led me to that. And then not fast forward, but throughout that time, my brother made it back okay. He was a Marine. And he had some symptoms, but I think there was always this thing stuck in my head about veterans were kind of coined in reference to the VA's response back then. About if you came back from Vietnam and you're having problems, it must be because you have a personality disorder or you're a drug addict. And that just made no freaking sense at all to me. Because I can say my brother, he came back and he worked his way. He became an executive with Eastern Airlines and he was doing relatively well. So there was kind of a disconnect between that. And so that kind of spurred my interest. It was almost a shift from looking at engineering and how do you make objects fly to the much, much more complex dynamic of mental health and how does pathology get established? How do you treat it and things like that? And so when it was time to raise my hand and come in, there were certainly things like GI Bill for, further education. But I really had made a decision, and I'd been working as a highway construction engineer. And it was like that fork in the road. I need to decide which way do I want to go. And the pathway towards becoming initially in the Army, a mental health technician, later a mental health instructor at the Academy of Health Sciences in Fort Sam, to getting a master's degree, getting commissioned in the Air Force, and being a mental health officer, all were kind of answering some of those kind of burning questions about how does this work? And that kind of led to an interest in veteran health, to include veteran mental health, and also kind of first responder health, because early in my career, I started working closely with law enforcement and things like that. But those are the dynamics that kind of led me to raise my hand.
Thank you. That's awesome. And I appreciate you sharing. And Tim, how about you?
I've got a storied history from my grandfather, just in the civil rights era, and just really the push to serve. And so I've got an uncle who's served in Vietnam as well, kind of like Bill's brother, who had 3 Purple Hearts, and you just go through it. And so when he came home, my grandmother would actually tell us, be careful how you address him and how you touch him, because he will wake up fighting. So she would actually tell stories about how when he got back, she would use a broom handle to tap him on the bottom of his feet to get him to wake up because he would come up thinking he's in battle and come up fighting. And so that kind of put some questions for me and kind of led that path for me, similar to Bill, that created that evolution in terms of how do I help my uncle? And then translated to, well, how do I help people who have this similar concerns or who were kind of thrust into a war? And now how do we help them now that they're back? We appreciate their service, but, the experience that the Vietnam era veterans got is primarily, and I would say, the primary reason why the OEF centers exist today is to make sure that there's no wrong door to come in when you exit the military and enter the doors of the VA. And more importantly, how you address that. And so for me, it was really kind of a full circle by helping my uncle and learning information and services and treatment for him. It really kind of set the stage that kind of, redirected my path in terms of joining. I joined for the Army College Fund because I knew I wanted to go to college, but it was really a way of getting into a system that would both address college issues and ultimately would get me in a path where I would actually end up working in mental health and being able to not only just kind of help veterans nationally, but to help my uncle as well.
That is excellent. Thank you both for sharing, and once again, thank you both for stepping forward and raising the right hand, and then doing all the cool things that you've done, because this is such an important topic that we're going to be talking about here in a minute. And you've written an incredible book about it, and so kudos to you. And just a note, I always wonder. I look back because one of my grandfathers was a World War II vet he was in the tanks going across to Berlin to end that part of the war. And there were a lot of times where he slept a lot and things like that. And I always wonder if there's things that I've probably missed that he did that may have been that. He was a funny guy, so that may have been it too. He may have been. His wife may have been discouraging that part of his behaviors. I don't know, but
it's really kind of an interesting thing about that group of veterans, the World War II vets, because they came back in a different way. They came back all together, so they had some time to decompress and kind of figure out what to talk about and what not to talk about. And and again, we had battle fatigue and a bunch of kind of nebulous terms for them. But one of the things that was significant as Tim and I worked in the Freedom Center with the other war groups, one of the things that we started to notice is a lot of the World War II vets, they just decided to be quiet about it. And so very often it would be, I don't know how many times I heard this experience from a family member talking about a grandpa typically. And what they would say is they would ask him questions about the war because they knew he or she was there. And typically they hadn't talked about it. And often in some of that life review, they might talk about it. And then you'd hear people say, he never talked about that. And they talk about some of their experiences of the horrors of war, like driving in tanks or things like that they just stuffed it. And they dealt with it differently. Some used substances, but for the most part, they kind of looked at it like something to that was then, this is now. And they had GI bills and things like that to help, and economic supports and get on with family. So they didn't really talk about it a lot, but it wasn't because it wasn't there. Gotcha.
That's pretty much what the experience, me as a little kid, I was his buddy and kind of followed him wherever he went. And, but he was someone who I started picking up an interest in it, and I would ask, but he really did not talk about it. And he would not, he just, he'd share a few things. And the funniest story that I have is what he would share things like that. He wouldn't talk about the actual fighting and stuff like that. And he was, just as a note, he was a tech sergeant who was in command of this, worked with the commanders in these tanks and all this stuff. And they were in some area on their way to Berlin, and a fight broke out, and he gets involved in the fight. And I guess wherever the MPs came from, he ends up trying to protect his own men from the MPs, and so he gets in a battle with them. And so it's a funny story because he shared this with me. He said, I got to tell you about the time I got busted to private in the middle of a war. He said, so they busted him to private in the middle of the war because he hit one or two of the MPs to get him off. And then a month later, they gave him back his stripes back. They gave him his stripes back, and then put him back in the tank where he was supposed to be. And so it was a funny story. I have those letters that are kind of cool where he sends eventually the the tech sergeant comes forward, those patches, and then eventually he sends back the private. Says, I got my other patches back. So, but that's an interesting thing. In the middle of a war, he's being punished because he broke up a fight. So,
oh yeah, there were jokes about folks they should put their stripes on with Velcro. They didn't have Velcro back then.
No,
but put them on with Velcro because they keep getting them busted and taking them off, and that's an easier way to do it. And then they'd reinstate them and patch them back on.
That would have been a lot easier. Yes, definitely. But you can see where they were hand stitched or something because what he did. I can only imagine what it looked like. So that's funny. All right. So at the beginning of your book, you have this quotation: "A veteran is someone who, at one point in their life, wrote a blank check made payable to the United States of America for an amount of up to and including their life." You list this as an anonymous quotation. Could you talk about what this means and why you included it in the beginning of your book?
Sure, you go ahead, Tim.
Okay. Well, Steve, we put that there because, one, we want to acknowledge when you think about the American population, at any given time, there's usually only between 3 to 5% of veterans in the military. So we think that's a large number, but when you look at the overall population, it's not that many people that actually raise their hand to serve. And what they're actually doing, which I think is very powerful as it relates to helping in their recovery, is that oftentimes we think of, I'm just, a stone maker and I'm helping build stones, or I'm helping build a cathedral. Well, they're literally, by their very lives and by their very signature, they're putting their life on the line should the military need them to go to battle. And for many that did not serve, it's still the same, because we still have those same missions abroad in terms of national disaster response, that we're putting our lives in danger, much like a firefighter going into a firefight. So I really elevate their services to get them to see that, because oftentimes we just see that I just served with my troops. I went over with my buddies. I was there because my buddy was there. But really, to put it in proper context that helps them to begin the process of healing is to really get them to think that, one, there's only 3 to 5% that are veterans at any given time in our country. And out of that 3 to 5%, 0.45% are combat veterans. So it's a very small academy when you start with that, and the fact that they served. And so I let them know from the start that I'm dealing with someone who stepped forward at the highest level of our federal government to give their service. And so the VA calls them entitlements. So you're not begging, you're not asking something, you're asking something that you're entitled to. And so by them hearing that, it changes the dynamic of woe is me or my service that no one will recognize, because sometimes, because we did this, so many valiant things in war, they don't get acknowledged sometimes. So there's no ARCOM for them or no medal that they can wear short of the Purple Heart. But it really sets the trajectory for them that I can see light at the end of the tunnel, and it is not a freight train coming at me. And I think that kind of highlights that for them.
Mm-hmm.
That's awesome. Thank you.
I'd only share, I echo what Tim says. I think that in working with combat vets in particular, the idea is it really speaks back to that small number. And I sometimes will tell folks, if you took 100 people, you're going to need more. Let's say 400 people, and you have maybe 1%, right? You only have 4 out of that 400 that actually are now in the military. 1/4 of those, so 1 out of that 4, actually goes to a combat environment. And it's one thing in peacetime, so I came in 1976. We're at the end of Vietnam. But throughout my career, there are some skirmishes and things like that. And I had a sergeant tell me in the Army, if you serve 20 years, you're probably going to go to war and have to kill somebody. And it's like, what? And the backside of that is someone's going to be trying to kill you. And very often that became some of the discussion with our vets around how unique it is. So kind of like we're talking about our World War II vets, Vietnam vets, when you have such a small number that have an experience, then who do you share it with, right? You could stand in an audience of 400 people as a veteran that had to kill someone in Fallujah, Iraq, or experience your buddies being killed, things like that. But it's kind of like, well, who do you talk to? Because you don't have that idea about shared experience. Well, you do, but it's with very little people. And one of the things, when I think about that with our Iraq, Afghanistan vets coming back, our active duty folks come back to active duty service. So they're back with their, quote, community of others that have served. But think about our National Guard and reservists who are distributed out through the United States. But when they come back, they go through about a 10-day, if you will, demobilization. And then they go back to being teachers and bankers and, workers in our communities, et cetera. And who do they share with? And so that unique signature on the check to include your life, to me, speaks to the really small amount of people that have that shared experience. And it was always fascinating because I think there was a time where Tim had that up in his office. And every now and then he'd be out of the office, someone would come in. My office was right next to him, and I'd go check out who it was. And I'd see them kind of standing there reading that. And just kind of, I remember one, I said, "What do you think about that?" And he looked at me, because he looked at me and he says, "Well, you and Tim know." I said, "Yeah, we do." I said, "Yeah, we do," which is kind of a unique perspective because, again, within that small number, there's a lot of therapists that weren't active combatants either in Gulf War I or Gulf War, the Iraq-Afghanistan war. But that blank check, that we signed voluntarily, really speaks to not only the number but the commitment, like Tim had said about. What else do you do that you would give your life for someone else because the government asked you to do this? And that's the uniqueness of that statement.
Very much so. Wow, I appreciate you both sharing that. And that's very powerful. And I can imagine having someone taking a look at it, if they're, just as they're reading it, what might they be thinking? So,
Sure.
It's very thought-provoking. So thank you. So I got to ask, what inspired you to create your book, Complexities and Challenges, Clinical Perspectives in Combat Veteran Treatment and Unique Needs of Military and Veteran Families? I mean, what made you say, this needs to be a book and we need to get it done?
Well, I'll go first on that one. So I had a presentation that was coming up. I think it was to possibly the National Association of Social Work. And I think at the time, Tim was the president for the NASW Ohio. And he asked me, he said, "Bill, can you do a presentation for one of our social work conferences?" And I was kind of working on it, and I was just kind of thinking out loud. Like I said, our office are right next door, so we could visit pretty easily. Plus, we had spent time active duty together, so we know each other really well. And Tim said, "Well, what do you think about complexities and challenges?" And I said, man, that captures that perfectly." And so the lecture, which was similar in the sense of the kind of work that we were doing at the Dayton VA and the Freedom Center, was to understand the complexities of not only just, if you pick any one of them, post-traumatic stress is an extraordinarily complex kind of situation. If you've had a trauma and you look now at various data that might say, you can look at data that talks about adverse childhood events, ACEs, from a study that was done back in the 70s. That's a good lead-in, but again, you don't just kind of show up in the military, you have your history as well. So the idea about complexities, in my mind, spoke to how dynamic this is. So kind of back to engineering, you can put thrust on a chair and it'll fly. Put a tail, some wings, you're good to go. It'll fly, it might crash, but you're good to go. But a person, in terms of the complexities that they have, are extraordinarily different than that. And so complexities, when you think about one condition like PTSD, another condition like chronic pain, blast injuries, and again, these happen with veterans and civilians as well, substance abuse in terms of how that gets established, or even partner relationship, because, we think about those four live at home, so that's kind of where partner relationship comes in. But the complexities of it speaks then to the challenges of how do you have a dialogue, therapeutic communication with somebody to build trust and things like that in such a way that you can effectively help a person heal and move from the trauma impacts of that kind of service in a combat environment to healthy, thriving living again. And so that title spoke volumes to me. And so for me, just about any other lecture that I wrote for, whether it be a community organization, Many of the lectures that I have at Wright State, same lead in, started to build this archive of complexities and challenges, coping with stress as a student, complexities and challenges, dealing with veteran healthcare. Became kind of for me, it's just been one of those titles that just captures the dynamics of what we're trying to approach. Because so often, I know we can be, in our bios, we talk about being a traumatologist. Well, you can be a cognitive behavioral therapist. You can be a prolonged exposure therapist. You can be a therapist based on the model. But the complexity problem and the challenges is that what do you do when it doesn't work? Because you have to kind of pivot and try and use something else. And some folks don't do that. And the cost of that is a veteran will drop out of care. Law enforcement will drop out of care. Fire will drop out of care. Because the challenge is how do we, the complexities are what you bring to us. The challenges are what we need to bring to the table in terms of providing some context of safety and trust, esteem building, a sense of control. We need to revisit that. And connection. I think that's the huge part. So that title, like I said, from when Tim first kind of said, hey, what do you think about this? Has just grown over the years to probably more than 100 or so lectures that at one point, a couple of years ago, Tim kind of called and said, hey, what do you think about putting these together? Which is really kind of what was the start of the book. And so little known, often like Tim will say, well, you're the colonel, I'm the captain, so you go first. But, one of the things that I thought about as far as why he's the first author in the book is that it was, his initiative, I think, to say, let's try and do this. I said, let's go. So, yeah.
Very cool. Very cool. Tim, do you want to add anything else to that?
Sure. I think one of the things that on the Colonel Wall I was able to do at the Dayton VA was to run out the first inaugural combat veterans group. Typically in the VA system, because there are so many challenges there in terms of how you provide service, you could have someone in a group. All of them have the diagnosis of PTSD. One might be from military sexual trauma. One might be for a car accident that they were after basic training and before they got to AIT or permanent party, they were hit on a bus and they've got trauma from that, as well as those combat veterans. And as we know, there's kind of particular slant with how you address all of those. But one of the things that the literature kind of pretty much says is that if you put folks based on just a diagnosis in the same group, it's kind of hard to work through it because the issues are so vastly different. A combat veteran is going to say to someone who got injured in a hospital setting or in a car setting, that's typical. But I got blown up. And so part of the pieces was to start a group specific to combat veterans. And since I was under the mantra of us as combat veterans and the Freedom Center, so we created that. As you might imagine, that created some whirlwind there because now you're treating the combat veterans different from anyone who served with that. But part of the piece is because of the therapeutic nature of what we'd be dealing with, they need to feel a great affinity that as they say in the military culture, when you look across the room, they've had boots on ground, been there, done it, and got 5 T-shirts to prove it. So it's a proven acumen that, Tim and Bill, they've been there. But part of the challenge of the great work we did, Bill knows the numbers of terms of folks that we saw in the clinic, but many of them now, because a lot of the work that we've done in addressing both the family context of their challenges coming back, is that many of them now have moved in positions where now they unlike us, whereas a trained professional, and I would kind of put my disclaimer out there, Steve, in the sense that part of us writing the book is typically a lot of the research that's done in VA systems or just done around the country is people who had family members that served and they wanted to give back. And so they did a lot of research, either in clinical social work, psychology, to improve on how we address our veterans. Bill and I have a unique perspective because in addition to being traumatologists, we're also combat veterans. So we have a more advanced on the ground kind of version. So when we're talking to veterans, as they say, I get it. Mm-hmm. And so that helps the therapeutic process. And so for me, that piece is kind of getting them to see that. And by starting that group, they realize that, one, this is a safe place and I can share my story. And I think that was the genius of the group, is putting them in an environment where they can share the story, because that small number, there's only the 1 in 4. But in that, everyone in that room, when they look around the room, there's a combat patch to back up what the service that they've done. And that kind of set the stage for their recovery. Fast forward 10 years later, we've got these folks now in positions of authority, power, influence in the community. Many have now written books, and they often refer when they give their lectures or talks around the country, if it weren't for the colonel and the captain, I wouldn't be here today. And so people are asking, well, who is this colonel and the captain? And they're like, hey, can you guys come and just show up? And I said, the bill, with our active schedule, that's kind of hard. But if we take what we did with them, put it in a book, and I appreciate Bill sharing it earlier about, because now when they read the book, like, yeah, this is what they taught us. And many times they would forget, but now they've got a book that addresses all of the 5 component areas, and it helps them guide other veterans that we may never, ever reach. It opens that door for them. And so I thought it was critical to, one, kind of put a stitch in time in terms of the history piece of writing the book, but also, and more important, is really, I value their service, and we want something that creates a legacy that folks can refer back to and said, I think we did a pretty good, decent job.
Excellent.
Sure. I would only add to what Tim said, and it's kind of like that final part that, as a therapist, I'm kind of downstream, but I might see, if I saw 8 people in a day for 4 in the morning, 4 in the afternoon, that's a small number considering the 2.8 million veterans, that we're trying to get that message out to. Even if I see a group, I'm seeing a group of maybe 10 once a week, that's a small number. And we hear all the time about how valuable this information has been for them in terms of, or from their wife, their spouses, who sometimes would come to sessions and kind of hear it. And it's maybe the first time they'd heard that, or it's not a modularized program because it's kind of tailored to them. And we both are busy, and we do presentations and things like that. And, depending on the class size, fall semester, it's still a limited number. But I think one of the things that I know when Tim and I met a few weeks ago, is to be able to have that information that people have said has great value to them. And in a book, it distributes much more widely. And hearing, I'm back 17 years from 2005. But when we were doing that work from 2007 to 2017, many of them now are either running their own groups, and they're using this information. So I think it's really a neat way for that information, like in education, we distribute it out by teaching others how to help themselves, but how to teach others how to help each other. So, yeah.
Excellent. And it really speaks to, think about what you're doing and how it helps. So I can't say enough about how it's cool, because when you read their book, listeners, it's one of those things where you really get kind of a better understanding, and it's written in such a way in which you will have a better understanding of what a veteran is dealing with, a combat veteran is dealing with, as well as what they're trying to do to help. So awesome. In your book, you refer to OEF, Operation Enduring Freedom, and OIF, Operation Iraqi Freedom, veterans and their health concerns and challenges. Could you take a minute to share with us the types of challenges they are facing as their physical and mental health is concerned? And I know that's a big topic, but could you talk a little bit about that?
Tim, you want to go first or me?
The Colonel.
Okay. So it's really kind of a fascinating thing to, when I think about being at the Dayton VA Medical Center and working with Guy Richardson, he was the director at the time. And I'm coming out of, again, a career of looking at a lot of different dimensions of what's going on. And Guy Richardson, when he hired me, he kind of said something on the order, in a metaphor, I'm going to give you an orchestra, talking about the clinicians that'll be in the clinic, but you're the conductor, so you need to make some great music, that kind of thing. So as we're looking at what people are coming back, we have some they call them clinical reminders in the VA. So you're looking at things like traumatic brain injury, you're looking at PTSD, and pain. Those were kind of the first 3. But I think as we started to see the different things that were going on, and keep in mind, we're also being informed by our Vietnam vets, because our clinic is strictly the Iraq, Afghanistan vets, but in the VA, we get Vietnam vets that come in and go, hey, what's this clinic about? And we tell them, how come? And sometimes it would be We should have had that when we got back, so we're glad that you have it. Or we'd get our Gulf War vets that would come in and they're still dealing with respiratory problems and things like that. So early on, you had a sense of like all these different things that were going on in healthcare. Some were mental health, some were physical health. But the key became around kind of amplifying the screening conditions. And so we developed what we called the 10-step intake process, in which what we were doing was we had our primary care doc, they would do kind of the basics, making sure that your respiratory functioning, cardiac functioning, endocrine functioning, neurological functioning, things like that were basically good to go, right? And then in the Freedom Center, we would screen for TBI, the blast injury related things. But TBI also, blast injuries also resulted in visual problems, because if you had any kind of ocular damage, it resulted in auditory problems. Because, if you get an eardrum ruptured, there are different dynamics with that. And so we would look for that. PTSD, we would screen routinely for that. We'd also look at chronic pain because, again, on the active duty side, people coming in would very often be treated with opioids, which is not a bad initial acute treatment. But by the time they're discharged, whether they're active duty or just coming off Title 10 if they're guard, now you got to figure out a transition. And so we didn't want to make the opioid situation worse. So we take a look at that and also ask specifically about substance abuse in terms of, are you using alcohol and things like that more? So we started to notice that with a lot of the Iraq, Afghanistan vets, clearly, they didn't have substance dependence issues prior to coming in or going to deployment. They had it afterwards, which was kind of unique. So that kind of set the stage for really just kind of a rubric around, was any of this stuff present before you left? Kind of that pre-deployment self, what happened during deployment, and what are we seeing in the post-deployment person, both in terms of mental and physical health. And finding out through the various screenings for these different conditions, and even asking, how are you doing with your spouse? If you were about to divorce before you left and you're about to divorce now, okay, well, that says things, but it's just going to get worse. And if we can do something to preserve the relationships, that's something that we need to do. So we found, looking at the myriad of the healthcare conditions that they had, screening, and using our nurses and social work case managers, not only to screen and say, yes, you have this condition, and finding out where in the system we could refer them to. But I think the biggest thing that we experienced was follow-up, right? Because our case managers would follow them. And for me, it was, we're going to follow you weekly for about 90 days, to anywhere from 3 to 6 months. And make sure that you're tracking all those appointments, because it's easy for people to say, well, I didn't go to that appointment or what. But if you lose continuity of care, that's when conditions just become chronic and are harder to treat. So I think just that kind of big question about, what kind of things they were facing, for me, it was important to do the screening and assessment, take the findings from that screening and assessment and get them into the stream of care for the relevant conditions that they had, and following that, follow-up. And I think the follow-up was probably one of the biggest things about the follow-up is that contributed to a sense of trust for us. It reduced their frustration in the system, because I would say to them routinely, okay, I want you to go to this appointment, and if something happens or you're not happy with it, come back. Don't just go home and never come back, because that's what people will do. They'll go out in the parking lot, cuss and swear a whole bunch, and then not come back. I want you, if you don't get any satisfaction in neurology, wherever you go, come back and see us. And we would say that for veterans, not specific to gender, because a lot of the female vets would come back and they would have changes in their endocrine system. They would have changes in their GYN functioning. They would have sexual trauma. And again, for a while, they weren't calling military sexual trauma PTSD, which is what it was. They would kind of make it seem as if it was some other nebulous thing, and we just need to call it what it is. And so Tim and I think other OEF programs really kind of shifted gears to make sure that we acknowledge that. But it was it's a problem, I think, so back to my engineering, it's a problem with a whole lot of variables, right? And so we got to figure out which variables are the most active ones, which ones are the lurking variables, work out the equation, and on the other side of the equal sign, making sure that people are getting in the stream of care and also moving forward in the goals that they had. Because, just because you've got health problems and mental health problems, our veterans, like Tim and I, they came in and they wanted to get their GI Bill and go to college. But they don't want to go to college and get triggered and then drop out. They want to go back and work. And it's difficult to work if you're cussing and swearing at all your coworkers because they're triggering your PTSD or something like that. Or if you're a female and you go back to work and some guy says something stupid to you that triggers a trauma experience there. So not only was it treating the conditions, but, getting them towards, kind of in the rubric of trauma, moving from being a survivor back to that idea about how do we get them to thrive again? Not only in their relationships, but their occupational functioning as well. And I think that's maybe the beauty of what they felt like they got from us in terms of that exchange.
Excellent. This is, I just, just any number of, what I hear you saying is that just any number of challenges can appear, mm-hmm. and that you really kind of have to figure out what their combination is, I guess, and what's going on there, especially if they'll be cooperative.
Well, it's funny because I know one of the, your comment reminds me of a spouse. So one of the vets was there, it was his first session, we were talking, and he said, well, can my wife come with me the next time? I said, sure, because, we need to, if they want to be included, talk to them about what's going on so they know. And at the end of the session, I said to her, so was this session helpful to you? And she said, well, yeah. And I said, well, how was it helpful to you? And she says, well, now I know what part of what's going on with him is PTSD. And I also know what part of what's going on with him is him just being an asshole. And I did the same thing. I started laughing and I thought, well, okay, I guess that's cool. Because that's what you need to know is that you don't want to be reactive to the PTSD. And if you are, you want to be helpful and nurturing. But the asshole part, yeah, that's yours. Yes, right. Not what we treat. Making kinder and better, but okay. So I thought that was fascinating, way to understand what works.
That really is. It's and I kind of imagine it had a little shock value to you too the first time. Yeah.
It's like, oh, okay, well, yeah, we're onto something with this partner relational thing.
Yes. Tim, is there anything that you wanted to add to that, or?
I think that was great. His overview. The piece that we always know, and again, that I know kind of anecdotally, and the lived experiences, remembering my grandmother having to tap her own son I think he was 19, he came back with her broomstick. And so it really speaks to that partner relational piece. And the veterans will oftentimes say, hey, I don't want to talk about this around my spouse. I'm like, but when you're having nightmares and you're kicking and fighting in your sleep, who do you think you're kicking? Who's seeing that? So she's already aware that there's something going on. She just may not know what it is, or he may not know what it is. And so that kind of opened the door, as Bill was saying, when we include the family, because oftentimes, as you said about your grandfather, if they're sleeping during the day, if you got up at 2 a.m. to go use the bathroom, you probably saw them not sleeping. So oftentimes when they were sleeping in the day, it wasn't because they just had insomnia. Most of them were very afraid of the night, what we call the night terrors, and just the things that mind would play tricks on them. And so for them, they would stay up all night long, 20, 30 years post their experience. And many family members would never even make a connection that they're sleeping a lot. I wonder why that is. If you happen to get up in the middle of the night, or you have a shift work where you work through the night and you just happen to stop by the house and see some of the lights on, that would explain they don't want to deal with that information or that trauma piece. And so they either stay up or they, engage in substance abuse to get drunk and then go to sleep, because it kind of serves the same function. But part of the piece is family members were very acute in saying what are some of the other presentations that was helpful to us in getting a very good assessment.
Thank you both. This is a powerful conversation here. One of the things, before I ask my next question, I wanted to, it's something, Bill, earlier you were talking a little bit about Vietnam vets, and there's a famous picture that when I read your book that comes to mind, even though it's more about the Iraqi wars and so forth, and I believe he was like the last POW, at least at that time, to be released, where his daughter's running across the tarmac to give him a hug.
Yep.
And one of the things that always, as I'm reading, and I was thinking about that image, because, one of the things that you deal with is the stresses associated with returning to the civilian world. And, that picture comes to mind because, they're happy to be reunited, but at the same time, I mean, what may have been part of the world that they also had to deal with or contend with after having been, part of a prison of war camp and for a long time, and then be separated, and then you're suddenly brought back together again, and then on top of that to return to some sort of something in the world.
Yes.
And I just wondering if you could kind of talk to that, not so much the picture as the events that you've just run into as you're trying to help veterans, combat veterans.
I think one of the things I would say, Steve, is most folks, either whether they learned about it in high school, typically where you can learn about it, if not, certainly we learned about it in college, a psychologist by the name of Abraham Maslow. So many of us are familiar with Maslow's hierarchy of needs, and I share this with veterans and they kind of get it. And I always talk about how the whole physiological needs, food, water, shelter, typically those are accomplished by your mom and dad. So you kind of get that, as long as you go out and play, eat, come back. Typically, then you get to your safety needs. But now you feel safe in the world. I feel safe. I can jump off that trampoline because I can handle this. I may hit the ground on my feet. I do good. But you're progressing through his hierarchy of needs, love and acceptance and belonging. So now you're probably in high school and you got your first girlfriend, first boyfriend. You're learning how to act and appropriately in relationships. And then self-esteem needs. So now you've actually been good at what you do. You're probably in college now. You're probably in the military now. And your self-esteem is tied to that buddy aid, that I'm going to be good at my job so that we can be dominant in battle or in just our training. And so you've gone through all of these needs issues. So now you get self-esteem. Part of the challenge is when you see the POW on the tarmac is that he's coming back. But when you think before he went, he was probably at self-actualization or certainly at the esteem needs. He's done this. He's got a Purple Heart. He's got all these awards and decorations. But here's the challenge. And they kind of get it when I share it this way. You've gone through all of these hierarchy of needs. You hit self-esteem, and then now you come back and you can't sleep because you're fearful of the night terrors. You are having flashbacks. You're having dreams. You're having throughout the day. You can see a pothole, but in your mind, we knew in driving in Iraqi and Afghanistan, you don't go over potholes because that could be an ID. So you go around them. So now the cop pulls you over because you went around a pothole versus driving over it, like most civilians. The challenge I would say to them is that part of the thing that's helpful for them to realize is that physiologically, in your mind, you're still at this self-esteem because you've been valiant in war. But psychologically, you're back all the way back down to safety needs. You're not sure, did I lock all the doors? Is the house safe? Someone can break in and try to hurt me and my family. So you're psychologically advanced in terms of your ability to care for your family, but it's retrograde in terms of safety. Well, typically by the time, we would just, you're probably 7, 8 years old, you leave your bicycle outside. That same bicycle outside is now a challenge for that veteran because they're wondering, is that going to be the precursor or someone will break into my house? So you psychologically go from self-esteem needs to a high level of function. Now you're back down to, can I trust my body? Can I trust my mind? Can I trust my emotions? And so for them, they kind of get it. That's part of, I think, the psychological challenges. How am I so valiant in war, but I'm crying because my daughter just, graduated preschool? And that lack of control is really, I'm trying to adjust, and which back to the title, the complexities and the challenge. I love my daughter, and I thought because I wanted to come back home, she kept me alive. But sometimes that may or may not be enough when the kid that you love so much is seeing that there is a dark side to how you survive. And that's the powerful story that they're not ready to share with family, but they oftentimes are ready to share with the Colonel and I.
Absolutely.
Gotcha. That's and it's got to be able to open up has to be a powerful thing, and to be able to talk about those things that, I would think would be powerful in itself to have to be able to even talk with you about what they're experiencing, to be able to put it in words, I guess.
Yes.
So one of the things that you note, and you touched on a little bit of this, in Complexities and Challenges, you note this: female veterans usually experience a higher burden of medical illness, earlier psychological morbidity, and worse quality of life outcomes than do male military personnel who are exposed to the same levels of stressors and trauma. Could you share a little bit more about this?
Sure, I'll go first. One of the things that happens is that, in the broader context, a combat deployment, there's being in the military, right? We're at a point where we actually have joint boot camp training. So men and women are training together in boot camp. In the last several years, that's relatively new. But in a combat deployment is, I'm not sure how I'm quoting, but I've heard it said, is a hyper-masculine environment, right? And so in that environment, women are physiologically challenged and psychologically challenged differently. On the physiological level, if you're a transportation person or a mechanic that's part of a transportation company, you're driving long distances. And so early in the wars in both Iraq and Afghanistan, something as simple as where do you pee and when is a challenge. Well, most people know that for women, if you don't pee as frequently as you need to, you run the risk of urinary tract infection, right? And so it took a lot of time to figure out, and again, to stop sometimes is life-threatening. So, you make the choice. Things like going to the restroom. When I was deployed, you always were with your battle buddy. And the reason women were with their battle buddy on the psychological side is if you go to the latrines, even though they're supposedly Cadillac latrines, that just means there's 6 of them in a row and a shower attached. But there often were men lurking, standing on top of the toilet, so you can't see it when you look in, and women were getting assaulted. We had units, again, our team, as a combat stress team, would go to a small unit or a forward operating base, and there were things like lotteries where the guys would figure out which of the women were single and see or married. There were 2 versions of it, and figure out which one could sleep with the unmarried one or the married one first. And again, it sounds like kind of an interesting challenge, if you will, but what that does is that totally disrupts unit integrity and trust. If I can't trust that when you're coming to me, it's for a legitimate reason, and you're just really trying to get my pants, that's something else. That just totally disrupts that. And it feels like betrayal. And so you have this disruption of trust and betrayal and safety along dimensions that were normal in a non-combat environment. Other things such as being able to take care of hygiene requirements were there. Again, the level of threat load was one of those things that for females, they'd come back and suddenly start having thyroid problems. And you wonder, well, what's going on with that? And kind of the explanation from endocrinology was that your system is used to threat and fight, flight, and then settle down, kind of come back to calm. But that's not that environment. And both men and women experience that differently. But for females, that was there. One of the things that we noticed, a female has 3 kids at home, deploys. While she's deployed, she's paying attention to her, taking care of her own food, go to the dining facility, the DFAC, and eat breakfast, lunch, dinner, wash your own laundry, things like that. And one lady and one female in one of the military culture videos that we use described forgetting her, she used her domestication skills. And she was home from deployment and the kids were running around kind of waiting for mommy to make something for them to eat. And she's thinking about herself and just they're not in the picture. Same like laundry, went and did her laundry and her husband had while she was gone. Now the expectation changes. So they're much more at risk of those kind of stressors impacting their family functioning. And women also, you have women that are coming back from deployment at higher risk of divorce, actually at higher risk of homelessness, interestingly. Not to mention a lot of the physiological conditions that are there. And so, the other piece to it was that, the stories about women aren't in combat roles. They might not be point of the spear combat roles, but if you have a female truck driver or their truck driver on the outbound, it might be if it's a male-female team on the outbound, the guy's the driver and the female's the shooter, right? Because that's their role. Coming back, she's the driver, he's the shooter. Well, the number of convoys that were interdicted by improvised explosive devices, small arms fire at a convoy, they became combatants. I mean, no question about it. And they were good at it too, which was kind of interesting because in some of our debriefings, the convoy came under attack, and actually it was several of the women that were mindful enough of the threat, drugged the guys out of the vehicle to safety, and they're kind of screaming, like people scream when you're being shot at. Or women were often, something as what seems like benign, like a contractor. Well, the contractors were the ones that might have $50,000 in cash to take to one of the community sheiks that were providing some protection for our troops moving through. So we paid them. The contracting system did that. However, in order to get that person to the location where they need to make the drop of money, they go with a combat team that might on their way stop to snag somebody. So suddenly they're in a firefight. Or chaplain's assistants. That's my favorite. Chaplains, they don't carry weapons. So the chaplain assistant is basically the chaplain's bodyguard. And so if the chaplains want to walk around and do stuff that's highly not recommended and suddenly come under fire, well, it's their female chaplain assistant, AKA bodyguard, that's now shooting for everyone's protection. So they're engaged. And I think the challenge that Tim and I saw was helping them make sense of their trauma experience, but also there's a little bit of a gender shift in terms of, you think about, those ideas about, some of the early authors talking about different roles, and men, they have a justice or an ethic of justice, little kids playing, break the rules. We're going to take our marbles and go the hell home. We're not going to play anymore. And girls have an ethic of caring and relationship. And for them, I think combat really disrupted that in a huge way. And so for women who thrive in relationship and connection, being in a combat environment where killing and things like that are the norm was a factor that for me, as a therapist looking at them, was hugely important to address. How are you reconnecting these kind of things? So we saw a lot of that, making sure that we had women that were dealing with that, to include things like anthrax. Anthrax shots affected women differently. I mean, it affected their GYN functioning differently. They'd come back and start having all kind of disruption and, recommendations for various level of surgical procedures and things like that, and find out that it was related to an anthrax shot. So women, from my point of view as a provider, really had a different take on, PTSD is PTSD, yes, but it's different. Again, I think it's different in how you kind of understand it, how you understand what's not processed and what the troubling dynamics are, and the context in which the person's life is operating. So.
Gotcha. And that's, I can only imagine just the title says it all. I mean, you're coming to the complexities of everything that all the different soldiers that you would be seeing and what they might be dealing with. One of the things that you've mentioned a few times is the term PTSD, and it's a term that gets thrown about in the media quite a bit, and TV and different shows and stuff like this. Could you explain what that is, what it's referring to, and the challenges that need to be addressed when you're talking about it? I mean, can you kind of give us more of a specific talk about what it is? Because most of us have learned from the TV doctor.
Yes. I actually normally start with kind of some psychoeducation with the veterans, because most veterans think that PTSD is a psychotic disorder, and it's actually not. It actually falls in the DSM-5 as an anxiety disorder. And so that helps them really kind of reprocess that when they hear that. Some don't. I use it that some people, not everyone will come back with PTSD. Some may have just generalized anxiety or just depression. PTSD is kind of considered the Cadillac of anxiety disorders. So when you think about generalized anxiety that most of us have on any normal day versus some type of agoraphobia, where you're now just really fearful of being in public places, which oftentimes is what a combat veteran is looking at, because a crowd, as they say, sometimes it's hard to show where a crowd ends and a mob begins. And so typically from post-traumatic stress, but the whole issue is in the terminology, it's your experience after you've gone through the trauma. So for combat veterans, while we're going through the firefight, we're trained for this stuff. We actually have become very good about, very resilient about it. So we do the work. And then now we're coming home. Now we got a process of what we call after action reviews. You know, now let's just talk about what you went through. Oftentimes, unless you send a therapist, you're not going to do the after action review, but your mind never forgets. There's a great book about the mind never forgets. And so your mind is trying to come up with, based on your value system before you left, based on how you interpret life. Now let's look at how you perform. How's the report card? Let's look at that, because that's giving some indication. So PTSD, post-traumatic stress disorder, is, I share with veterans that if you're diagnosed with PTSD, if I put you back in a combat zone, all the things that are problematic for you home in Ohio or in Georgia go away. You're not sleeping in a combat zone, so you don't have to worry about insomnia. You're constantly going all the time, so you're responding to the threat quickly, real time, not a problem. The challenge is, how do you respond to those triggers where you are always kind of hypervigilant about what's going to happen? Is it someone going to break into my house tonight? How do you deal with that when you're in a peaceful environment? So that becomes part of the challenge and kind of helping them to work through that. So part of the piece is looking at, one, it's not a psychotic disorder. You're not typically, as they would say, layman's terms, crazy or you've lost it. You're dealing with a normal reaction to an abnormal event. And I think for a lot of people, that becomes powerful. A normal reaction to an abnormal event. Again, 3 to 5% of the country at any point in time are veterans. That 0.45% are combat veterans. So it's like walking outside and seeing a Chevy or a Ford versus walking outside and seeing a Lamborghini. Now you wonder, where's the doggone battery? I know where it is on a Ford and a Chevrolet, but where is it on this Lamborghini? Never had one. So now I need someone to even tell me, you buy the car because you got the money, but now you got to have the salesman tell you how to open the doggone thing up. So I think that's the issue of dealing with PTSD, is helping them to understand that this is a normal reaction to an abnormal event. And that secondly, it's an anxiety disorder. It is not a psychotic disorder. We're not dealing with schizophrenia here. We're not dealing with, psychothermic disorder or borderline personality disorder. We're dealing with a heightened anxiety issue. And that, I think, speaks volumes when veterans, because now they realize, oh, so I'm not crazy. I'm just hypervigilant. Absolutely.
That's all. Just very, telling. What I want to say is it's very powerful, and I keep using that term, but it really is understanding that, because I mean that's kind of how it's presented throughout. Lots of the, I keep hating to use this term, but the media or the TV shows or whatever is as if it's something that it's really not. And
there's a lack of failure to thrive. Most veterans will tell you they come to therapy not because of a diagnosis. They come to therapy because oftentimes they're dealing with the ambiguous loss. What does this mean for my life, or the moral injury? I was raised not to shoot, kill, and I did it. So I feel guilty. So I need you to help me to deal with it. And that's what the veteran presents at the VA with, or presents to their therapist with, is they're really not there because they're really invested in the care. They're really there. How do I deal with the nagging moral injury question, or how do I deal with this guilt I have around it? And it's really working through that. In a normal environment, you wouldn't be carrying a gun anyway. You'd only have it at home. But in this environment, you are loaded to the gills with weapons and ammunition for a very reason. It's not because they like us. They really want us dead. I mean, that's really the art and goal of war, is to kill your enemy before they kill you. If I if I shoot them, they get a Purple Heart, but if they shoot me, I get a Purple Heart. The goal for us is to make sure that they get the Purple Heart and we get the commendation medal, not the other way around. So there's a kind of valor in doing that. But if we were machines, it'd probably be an easy fit. Robotics, working in the Amazon factory, but we have thoughts, feelings. We have the ability that other species don't have, which is we are different in that we have self-reflection. I did the work. Now, how do I feel about the work that I did, which is our own kind of educational report card. And so they come in with those presentations because they're really trying to come up with how they deal with that. And for many that open the door to suicide, usually it's because they answered that question in the sense that there was a moral failing on my part. I should be able to suck this up. I should be able to deal with it, as opposed to this is tough. Number one, you're 0.45%. So there's not that many of you to go around to talk with about what you went through. So it's easy to post-Vietnam or even World War I and II is the stuff that just don't talk about it and life's going to be good. But we all know what happens when we bottle up, baking soda with water and stuff. It's going to bubble up. And the issue is when it bubbles up, I can't control when it comes out. Gotcha.
And something you mentioned in there, I was wondering if I could get you to go back and kind of explain what it is. You mentioned ambiguous loss. Can you kind of really tell us what that is?
Yes, ambiguous loss is really about it's unclear or issues that you're dealing with that there is no clear path, no clear answer to, or a situation that has no answer. And if you don't have an answer for us, there's no resolution. So for many of us, the question is why. From the time we were little kids, we would ask, why do zebras have stripes? Why do cows look white on the outside, but how do we get chocolate milk from a cow? And so it's that whole kind of thing, that questioning. And this is no different for the combat veteran. I did my job. Why am I not getting the service in the VA? Or I did my job. Why am I being mistreated? Or I did my job. Why am I struggling? I should be able to do this, change my baby's diaper, or I should be able to I made chili before I left for the war. It's a common thing you'll hear. They were good cooks. And now they come back. Now that bowl of chili, you can imagine what it looks like when you look at it now. If you've seen a brain trauma or someone shot and you saw a head injury. So for many of them, something as simple as they were known for their famous chili, they cannot make it anymore. So that ambiguous loss is, how do I deal with this unknown thing? We shot, but did we kill anyone? I don't know if I did, but I'm going to assume that I did. And now I'm feeling guilty and I can't move forward. And so it becomes ambiguous in the sense that we're not really sure. That's the ambiguous piece. The loss is something happened and I'm trying to make sense of it. And the answers in my mind oftentimes before therapy is that you were just guilty. You were wrong. I mean, you took a life and you had no reason to, as though we were walking in a shopping mall and you just decided to shoot someone. Well, I mean, we were put in a combat zone. They were firing us and we had a job to do. Our lives would be lost. So we did the job. And now we're dealing with the ambiguity of that, how I did it. There's the politicization of, was it a war we should have been fighting, those things. And so it opens a lot of door. And I know the Colonel can speak more about it, but it really opens that door in terms of how do I make sense of this? And that's really what gets people into treatment.
So I would, so your initial question about PTSD, and kind of the media versus kind of the what, I like that, Tim described it as essentially it's an anxiety disorder. And I think of all the different conditions that are out there that we might treat from a mental health standpoint, one of the unique dynamics of post-traumatic stress disorder, PTSD, is that it's event-driven, in that something had to happen to the person in terms of an event in their life. And typically it has some characteristics to it that were life-threatening and various things like that. But I think the significance is that when I talk to somebody about what were you like before the event and after the event, and then ask them, Tim and I use a thing we kind of refer to it as a symptom map, but it really kind of tracked the diagnostic manual's criteria. But, normally after event, and you ask the person about, where do you notice things like re-experiencing in terms of, where's this, I use the phrase with people, where do you notice it showing up again? Right? Because that speaks to, something sounds like, smells like, those kind of sensory kind of things. I think earlier in our conversation, we were talking about Tim was mentioning about avoidance, and the number of veterans that we would see that would go to, go shopping in the middle of the night, right? They go to Walmart or someplace like that, Costco at 2 a.m. if it was open 24 hours. And part of the reasons was that they knew they weren't going to run into someone that was going to trigger them, because that whole idea about sensory triggering something reminds us of the trauma event. And so they start having avoidance, and avoidance is tricky because avoidance feels good. It feels better than what it feels like to be confronted with the event or the issue that reminds us of the traumatic event. And so that's there. And so people avoid people, places, and things that remind them of the trauma. And then I think one of the other things is how a traumatic event impacts our thinking. So we kind of start getting a little bit negative. If we go from maybe a worldview that people are good and fair to people aren't good, they're not fair. You also see effects in terms of a person's spiritual functioning starts to get impacted that way. And so, again, when those are there, I think that's a place where we start to see some of the impact on certainly partner relational functioning, things like that. And then the piece that often trips folks up is that it's in the category of arousal, but it has to do with being hypervigilant and having a low frustration tolerance for stuff. And you're irritable and angry a lot. And there's lightning outside and suddenly you think it's a bomb that went off. So you're doing things that can be embarrassing and things like that are there. But I think to take some time and kind of walk a person that's had a traumatic event through what those symptoms look like for them and have them kind of acknowledge it, they do like Tim said, oh, that's what that is. And again, one of the impacts of trauma is control. And while, we can't control everything, and some things we can't control, we need to adapt. Well, this is one of them, and that we need to be mindful of that. One of our veterans, it's kind of an interesting part about experience, but, our mortuary affairs, he's a mortuary affairs Marine, and he was in our local cheesecake factory. And somebody was looking at him funny, at least the way he described it to me. And what it was doing was ticking him off because it reminded him of a casualty that he had to process in terms of mortuary affairs. And so now he's hyped, right? So that arousal's up. He would like not to have been there. He's got some intrusion, coming in. And all of a sudden he's sitting there with his wife. They're supposed to be having a nice evening. And he stands up and yells, if you can imagine, in Cheesecake Factory, yells, "I've put more MFs in body bags than are all you people sitting around here." Now, just imagine what happens next. Well, everybody's like, what? What? And they're looking at him, staring at him. His wife says, sit down. And he kind of is automatic and sits down. And he's kind of breathing heavy. The waiter comes over and says, one of these, "Are you okay?" "No, I'm not effing okay." And says, "Well, can I get you some cheesecake?" And he says, "Yeah, to go." And so he and his wife left and had that cheesecake. But that kind of story is repeated with many vets in terms of its intensity, from somebody that has that kind of thing all the way to low intensity. Another place that this happens is our student veterans. They go to class and they want to sit in the back of the class. And, sometimes everybody wants to sit in the back of the class, so there's nowhere to sit. So there's so many different sensory triggers and things like that are related to post-traumatic stress that when they're going back to their work or their academic environments, it makes it difficult. And so I know both Tim and I have had veterans who tried to go to school, found that the classroom environment, sometimes maybe a professor might say something like, "Well, you're a vet, so you're now the vet for the classroom," and wants them to explain something about a situation that they don't want to talk about. And so those are the kind of things that, we start to see with our veterans. One of our veterans in school, the class was going around talking about, the term was self-efficacy. Tell us something you're good about. This is one of those introductory exercises. So they're going around group, and he can see it coming. He's kind of thinking, well, what am I good at? What am I good at? And so the person next to him kind of explains, and now it's his turn, and he's quiet, and he's processing, and he's stressing, and he's like not sure what to say. The professor says, tell me, what are you good at? And he starts sweating, and he blurts out, killing. He's a Marine vet from Iraq, and he is good at it. But in that classroom, you can imagine he blurts out, killing is what he's really good at. And he can sense as everybody just kind of, what's with this guy? And he starts crying and gets up and walks out of class. So the thing about PTSD in part of the work is it's kind of fascinating is that it's kind of on the neurology of it, but when your brain gets a trauma, it wants to help you remember how to not be exposed to that again, right? In combat or first responders, unfortunately, they do have to be exposed. Combat vets until they're back from their deployment, Vietnam vets until they got their return date, World War II until everybody came back. But the point is that your amygdala, your neurobiology is looking out for things to remind you, to protect you. And so sometimes when vets would say to me something about, this happened, my first response is, you need to say out loud, thank you, brain, you're working for me and you're helping me, because that's what really is going on. Because if it's something to protect them, then that makes sense. But often it seems like something to avoid. But I think usually kind of midway through therapy, they kind of recognize part of the healing is acknowledging that, a little bit like the neuroception scenario of, you look on the ground and you see you see something. Is it a stick or a snake? Well, it makes a difference. You go bend over and that bad boy is, doing the, Mr. Hips thing, and it's poisonous. You don't want to pick it up. But if it's a stick and it's just kind of a curly stick, then okay. But for that little, those milliseconds, that's what's there. And so PTSD changes us in such a way to protect us from being exposed, and it protects us through what we often, there's one of the section of the book that talks about some of the long-term challenges around working through PTSD, and that's what those issues about triggers are about. But I think that's a significant part as people kind of map out, what do I have? Because everybody doesn't have all of it, everybody has some of it. And then how to work out where do I notice it and what do I do with it? Because I can run away from it or I can stay there. For me, I'm driving down the road, and when I first got back, I'm with Mary, my wife, and kids. We're in Beaver Creek, and they had built a bridge over Route 35. It's one of the local roads. And as I'm approaching it, I'm looking at it, and I see people on the bridge, which is a big flag negative for me. So I pull the car over, and excuse my language, I said out loud, shouldn't have, I said, somebody needs to get out of the car and put some rounds up on that fucking bridge and get those people off of there. And Mary looks at me and said, what? Bobby, my high-intensity Army son, says, oh, cool, Dad, I'll do it, but I'm sitting there thinking, what in the world? And it took me a moment to recognize that was then Iraq. This is now Beaver Creek, 2007 or 8. And I just need to breathe and calm down and things like practice, again, what we preach. But again, it was my brain helping me recognize that there was a time when going under a bridge with people on a bridge, something as benign as that, was threatening, because we had an event where we drove underneath a bridge early in our deployment. There were people up there. They ran to the other side, pushed concrete debris over the bridge, tried to disarm our vehicle. Small arms fire came later. They didn't disarm the vehicle, so we drove off. But it was just one of those shock, scary things that my brain recorded. And so when I saw things then, that was there. Again, 17 years later, I don't respond that way. My brain recognizes that that's not a threat. That's just construction guys, things like that. So I don't make that big swerve. Tim had mentioned about guys doing things when they first get back, driving erratically and getting pulled over. And the cop asks them, why are you driving erratically? Have you been drinking? And they don't even tell the police officer that, well, really, I saw a bag of trash in the road and thought it was the bomb. So they just made a really fast maneuver right in front of the police. and the police pulled them over, but they didn't want to say what was going on because, again, they were triggered by something like that. And the triggering, while it's painful and difficult, is there. And it happens along all sensory dimensions. And so we were working with a group of police officers yesterday. I mentioned about being Southwest Ohio critical incident stress team. And we were kind of in the debriefing and we're talking about kind of what do you remember and responses. And I remembered kind of thinking about sensory, you often don't think about the gustatory, your taste sense, but if you've ever done CPR on a human, whatever you were eating or taste before that, when you put your lips to that person, they start doing, rescue breathing for them, there's a taste transfer. And that taste later will show up. And sometimes you'll just find yourself maybe eating a Reese's cup and feeling sweating like crazy and wondering what in the heck's going on. And then you've got to make the connection because your brain wants to connect the threat message. Is it a threat? Is it pleasure? And the message might have been that I ate a Reese's cup right before I did CPR on that baby that died. You see, and so those kind of events are loss events, not so much trauma, but they're trauma-like. But that's that area of what I think about when I think about PTSD. I got an event that's happened, and then there's this specific symptom group that takes place. In regard to ambiguous loss, one of the things that we learned about, people are there one minute and they're gone the next, right? And so it's the idea is ambiguous. Well, what happened to them? And our brain wants to understand, sometimes when people deploy, the idea is that before you deploy, you're physically present, but psychologically absent because your brain's trying to get ahead of what I need to do. But once you're gone, now you're physically absent, psychologically present in the minds of folks. But people have all kinds of things that occur, everything from a murder, that can become ambiguous. Somebody dies suddenly, things like that. In a combat environment, they're there. In normal life, they're there. So I think we thought it important to give some time to talk about that ambiguous loss because I started noticing, and I'm sure Tim did as well, that was kind of one of those areas where people were really kind of struggling with, like you grew up and a parent left. Think about, I've read studies that talk about for female Army veterans, as many as, it was almost like 60% have had, a single parent scenario where a parent left. But think about the ambiguity that goes with why did my dad or my mom leave me and my brothers and sisters? That kind of thing is there. Sometimes chronic illness, we see veterans that come back and they're different. And sometimes we'd be in session and either a family member would say, well, I liked you better the way you were, right? And so the ambiguous loss issue there is, well, my identity has changed. We think about who I was before. I'm this happy-go-lucky person, life of the party. I come back and I'm now quiet. I sit and watch TV and the TV isn't even on, kind of things. I don't engage in the party. Those kind of things, I've lost that person. Sometimes a person will even say, I'm not the person I was after being in a, kind of the psychology of killing, if you will, but after you're exposed to that kind of stuff. When I think about ambiguous loss, I think about being Army basic training. And the first time, and I grew up hunting, not a whole lot, but hunting, in Northern Ohio. We'd hunt pheasants and rabbits and deer, and typically, we eat it or give it to somebody. But the first time I was in Army basic training and I'm on the range and I'm sighting in a rifle and I'm looking at a silhouette, kind of like I see Tim's silhouette, right? But I'm looking at it and that's a really different sight picture than ever, right? Because it's a human sight picture, right? And so then fast forward to deployment and all those kind of episodes to shooting at and probably shooting people. There's a loss of that part of me, and it's ambiguous. I didn't, if you lost something, it's ambiguous by nature. I lost my keys. Well, where are they? And the idea, well, I haven't found them yet, assuming you'll find it. But a lot of these things aren't coming back. And I think to give our combat vets and their families some understanding of that, and encouraging them to read more about it as it applies to them, I think is a huge dynamic in regard to just that concept of ambiguous loss.
Got it. And I appreciate you guys taking time to explain that term, because I thought I understood it, and it really makes more sense now. Thank you. One of the things that I've got to ask about is, if you had a chance to talk with families of soldiers that are returning from a war zone deployment, I mean, what's something that you would want to tell them about addressing challenges that may appear? I mean, we heard Tim talk about the person who has to poke her son with the handle because afraid of how he might react, and I mean, what would you tell him?
Well, I think my biggest message is kind of know what you have, right? How I've changed, because I use the metaphor a lot about what were you guys like before? What are the things that you now have as part of deployment? And as you're trying to work out the redeployment stuff, how do you want to be? And as I was looking at kind of the idea about identity development, Tim had mentioned about Maslow's hierarchy. If I boil it down in terms of character traits, right? What are the character traits that you'd want to have? And actually, I had a worksheet for a while that was from, if you were writing a book about a fictional book or writing a play about character development, what are the character traits that you want to have? And so I asked them, well, what were, did you have things like, were you truthful and honorable and courageous, things about values? And how do you want that to look? Who do you want to be? And sometimes I'll ask people, have you ever been in a play, right? And most people have been in a play at some type, either in high school, college, at school. But whatever character you were going to be, you had to learn some lines, right? And you probably flubbed the heck out of your lines. You're probably, cut. Let me go back over. What was the line? Things like that, because that's a little bit what it's like when you're back from deployment and you're trying to be you, but you're different, right? So you got to figure out what are your lines and be flexible enough to, if you're flubbing your lines and you're pissing your spouse off, stop. And don't get into blaming, because the more you blame, you can't fix anything you blame on somebody else. You got to own it. And hey, I blew my lines. I'm sorry. Much like I tell you about driving under the bridge, I needed to look at Mary and Mars and Bobby and say, hey guys, I'm sorry. This felt just like it did when I was deployed. And that's kind of where I was for a moment, but that's not where I am now. So it's back to that. How do I want to be, and actively practice it? One of the fellows that I see, he used the term, I got to work on my, I work on my resume. Everybody gets this, on my resume for my job, and I've got to look at my communication, all those different things that go on a good resume. And he used the phrase, what's my husband resume look like? Because I said, well, you need to work on your husband resume. It's almost the same kind of thing. What are those qualities and characteristics that you want to be known for now, post-deployment, and practice that? And just like almost anything else you want to be good at. If you want to learn a new language, you got to practice every day. If you want to learn to be more compassionate, you want to learn to be a better listener, you want to be better communicating, you want to be better at conflict management, you want to be better at intimacy, whatever it is, you know where you are, but practice what it takes to be better at it, and ask your spouse, partner, coworkers, etc., how am I doing? And you'll get there, because it's there's the therapy part, but there's also the growth part, And I think that one of the statements on the cover, from Martin Seligman, who does a lot of work around suicide, is the idea about treatment's not just fixing what's broken, because that's kind of, well, I'm broken, and you hear this. In the media, so such and such is broken. Yeah, okay, there's that part. We'll work on it. But it's also, kind of like that strength-based part, which has to do with nurturing what's best within ourselves. We got to nurture that. So those characteristics of you that were good before, let's keep those strengths and work out some other things that, maybe weaknesses, maybe not. They're just how you want to be in the world. And let's practice that.
Gotcha. One of the things that, and I think it would be so important because, just knowing what you might be experiencing or might be seeing or might not even realize that you're seeing, and having something to help you deal with that or recognize it would be so important. Who have you guys writing for? Who are you keeping in mind when you wrote Complexities and Challenges? I mean, who is that target person that should read your book?
Well, I think anybody that's a veteran of anybody that's a combat veteran for sure. I think anybody that's even a peacetime vets, because they experience trauma of various types. They feel those kind of betrayals and things of that nature. Right now all over the media is, if you drink any water at Camp Lejeune, talk to this lawyer because there must be some big cache of dollars, but that's not going to help you understand kind of what your role was in being there. So I think our veterans, certainly our combat veterans of any kind of war group, our veterans in general, I think our first responders, I think our educators that have student veterans, in their classrooms. I think our student veteran organizations are another group because even though I was talking to my class a few weeks ago and we were talking about the whole redeployment thing and coming back. Well, we've been out of Afghanistan since last year, but the piece that's there that Tim and I noticed and did some research about is it can be as much as 7 years from the time a person comes back from a deployment before they seek help. So that's a long window of cooking this stuff. The other piece is that if only about on a really good day with our Iraq, Afghanistan vets, 50% are seen in the VA, that means half of them are not. And so if people are doing some level of self-help, that's going to be there for them. I think that that therapists, people that are doing training in schools, academic environments that are teaching psychotherapy, I think that would be helpful for them to take a look at that material, not as the source material necessarily like the research articles and things like that, but much more conceptually designed. And then I think in our first responder community as well, because, what I start hearing is some of this material should be taught in the academies, whether it's fire, EMS, police, those kind of contexts. So I think that for me would be there. And certainly when I say veterans, family members as well, because for them, sometimes vets don't want them to be part of their therapy, and that's fine. But they need a frame of reference to understand what's going on. And sometimes that frame of reference is what helps them understand enough to open the conversation because they're using some of the same language. Or they might even say, well, hey, Bill and Tim in their book say this. And so, that might help them, open up a conversation. Because I think sometimes that's one of the biggest parts is just the willingness to have that conversation. And I think, probably, I think it really isn't a specific group. But I think the other side is that I think that anybody that's dealing with, stress-related kind of injuries from work, I was thinking about this work a lot as it related to our COVID response in terms of different dynamics going on with our nurses and healthcare workers that were going through 2020, 2021, going through burnout. I thought a lot about our nurses and folks that were deployed, and our medics that were deployed and what their experience was like when they get overwhelmed with, combat casualties and how they needed to regroup and go back to work. So I think in a healthcare environment, that would be another audience that I think would benefit.
Very cool. Very cool. The, one of the things that I want to just kind of give you an opportunity to suggest something maybe. If you had a chance to talk before Congress and say, there's something that should be looked at with veteran affairs, or there should be something that should be looked upon with veteran medical needs and such like this. What would you want to make sure that you told them they need to look at and address?
Well, that for me would fall in two directions. One, I would think about screening and assessment. You hear like nationally stories about, anxiety is a big issue, and we've got to have in primary care screening for anxiety. I think if I were talking to Congress about the veteran affairs, I think that the work that was done in the freedom centers, the OEF, OIF post-deployment clinics, and every medical center had one. We just happen to call ours the Freedom Center. But I think that the work that those centers did in terms of screening, assessment, getting our veterans into the flow of care, and then providing care and follow-up in terms of case management should really be kind of the national model. I think that like I said, for me, I'm learning, the idea about we stand on the shoulders of those who come before us. Well, we learned a lot from our Vietnam. That was the last big conflict about what not to do and what to do. We know that we need to not just, it's more than just substance abuse and things like that. So I would say the screening. I think we would, in regard to that screening, be more mindful of rather than trying to teach things or treat things one at a time. I think the whole idea about co-occurring disorders, which is what the P5 model is about, is that you have to work them at the same time. So I think that that's an important part as well. And then again, because if you're a Guard and Reserve as opposed to an active duty has access to mental health resources. Tim and I have worked at the VA. We've worked at Wright Pat Medical Center. We've worked at other active duty facilities. So our active duty folks probably have better access to that full spectrum of physical and mental health. But on the VA side, I think that they need that access. And so the CARES Act, which presumably allows, if we don't have enough mental health resources or physical health resources, we can move them in the community. I think there needs some rework, because it's not to suggest that, in the greater Dayton area, we only have so many therapists, right? So, and many of them are already booked. So you got to figure out how are you going to do that. And I think that with our Guard and Reserve, we got to be mindful of cost, because if a person, if I said, so like marital therapy, marital problems is not typically covered by insurance. It's not covered in EAPs. So if you're having, the partner relational problems, that's going to be out of pocket. So I think that one of the things about out of pocket expenses is people won't do it. I've talked to couples before, and if I'm going to charge you $150 a session, right, twice a month, that's $300 a month, right? You might be better off, you and your wife, to go have fun for $300. Have a really great dinner, go to a super movie, laugh like hell. That's probably going to do you as much as, what we're going to do in an hour and a half. So I would talk about how do we make sure that there's not just a slush fund, but funds that are available for veterans that if they need to seek help and they found a therapist that they feel works well with them, that they can access that without a whole lot of red tape, either for them or for the therapist, because a lot of therapists go to cash practice because of all the challenges with insurance. And I would also probably ask about, on the academic side, that making sure that there's a good link between, if there's a local military facility or VA, that the student veterans, whether they're service connected or not, if they have any needs, that they can access that either through their, like here at Dayton, at Wright State, they have a Veterans Military Center, and a lot of universities have those. But I think that if there's some funding flow to those organizations in regard to access to care, and it might be counseling, not necessarily full-blown therapy, but I think that the dollar issue in terms of who pays, I think could be significantly improved. But I think those big things would be, the OEF, OIF post-deployment clinics have been a model, and that they should, while again, they might have wound down, that should be a big model for how the VA, structures their care.
Excellent. Thank you so much. It is something that, listening to you as you talked, I think we have gotten better, at least, at some of the things that we do to try and help as we've identified more. Because, you go way back and you're talking about a society that pretty much said, you just need to kind of put it out of your mind and you'll be fine, and to coming forward and really understanding what it was happening in these different ages that caused them stress and trying to find them solutions. So,
well, a big thing is, of all the different dynamics, one of the things that trauma experience, whether it's formal combat-related PTSD or adverse childhood event kind of trauma, all those kind of things disrupt our emotion regulation, right? And we're kind of operating at a time where as things are gotten polarized, you can find someone to support your ideas and things like that. Okay, fine. But to what extent we can contribute to helping people learn emotion regulation skills. And I know Tim does a lot of that with dialectic behavior therapy, but emotion regulation is huge because emotion regulation is counterbalanced by acting out. And again, acting out can be if I feel a burden to myself, to my friends and family, from pain, from a future that just looks bleak, that's where we start to see things about suicide showing up. And one of the dynamics for me, a veteran that Tim and I have worked with, he committed suicide in the end of June 2020. And in his context, that idea about ideation to action, which is that idea about, we have a lot of people that have thoughts of harming others. The Violence Project talks about school-related violence in schools and universities. We talk a lot about suicide, that self-directed violence. But one of the key things has to do with that idea about, in terms of what goes from an idea about something, hurt myself, hurt others, and action is that issue about regulation and recognizing what's hyping us up in a negative way and what's calming us down. And learning those kind of regulation skills is just important. Other countries like Denmark, they teach that in elementary school. They teach different games to help kids learn to regulate that. For us, we kind of wait until you've probably gotten into trouble, either in school or something, and you're sent to the principal because, somebody said something, pissed you off, and you smack someone. Well, that's that kind of thing. Well, we need to learn to regulate that. And we know trauma, adds to that. So we're kind of has a little bit of a quicker trigger, if you will. But I think that emotion regulation for me is kind of a constant theme of learning just to kind of calm myself down so that my past trauma events, my past losses, kind of the wear and tear of the day-to-day, or the grief and stuff from things that have happened don't overwhelm me. And, we're post COVID. But if we've lost so many people, and people have lost family members throughout. So we've got to learn how to work that stuff through. And I think indirectly, the material in the book kind of speaks to that. But emotion regulation is just so important. If I had one skill to teach, it'd be that one.
Excellent. We're getting close to closing, and Tim and Bill, and before we go, and Tim, is there something that you'd like to add to that? I'm sorry, I almost didn't ask you.
No. I definitely concur. I think having been the chairman and the president of the board for the National Association of Social Workers, I worked very well with a lot of the congressmen and the senators in the area in terms of how do we improve the service delivery. And as Bill said, the whole issue of the red tape. And one of the things that we took pride in the Freedom Center, we used the phrase, there's no wrong door. Mm-hmm. No matter where you come into the VA system, if there was an appointment you had, rather than tell you it's still on the third floor, take a left, walk down, and then it's a right, we would take the time to walk you there. Because part of bureaucracy is we assume that you're as intelligent about the information that we're sharing or giving as the veteran or as the staff is. And the issue is, as I would say all the time, this might be my 7th patient for the day, but this is their first experience with me. And so oftentimes that's the model that you will typically see when we engage in bureaucracies, that they just assume that you know what I know. And so when I say, well, no, you don't have it on the right form, or you don't have it on this, oh, that's good information to hear, but can you give me a format of what it looks like, what it should look like? Now you've given me some education, as opposed to I can do it 10 times and you'll say, that's not right. That's not right. But if you give an example, we can follow through on that. And so it's really, to Bill's point, a lot of the emotional regulation is not necessarily because the veteran wakes up and says, you know what, I just want to be pissed off today. Or, you know what, yesterday I woke on the right side of the bed, but today, you know, I'm thinking to wake up on the wrong side and everything goes wrong. Usually that's that emotional regulation. And unfortunately, sometimes it's really how the veteran perceives our action. Do we look like we're threatening to them? Do we look like we want to care? And one of the things that I always say that veterans don't really care about how much you know, but they do care about how much you care. And that's one of those quantities and variables that people can sense, whether it's over the phone, your response, or whether it's in person, your response. They can sense really, really good. And as I share with a lot of married cases, that if I can show empathy towards your wife or toward your husband, now you're married to them. So it's incumbent upon you to kind of model that same behavior, because the issue, oftentimes we're dealing with the emotional regulation. It feels like a threat environment. So I'm going to respond to the threat as it was a threat, not realizing that the situation is a threat, not my wife or the kids.
It's amazing what you guys come together to do, and working with the patients that you have, and to help them become part of, to overcome whatever those challenges are, and to become part of our, to get them back into the world that they'd like to be part of. I guess is where I'm going with that. It's awesome. Tim and Bill, before we close, could you let everyone know where they could connect and learn more? Do you have a place you'd like me to send them to, put in the show notes, anything like that?
No, for me, so the Center for Life Stress and Psychotherapy, my email address is William and Mary. It's the one you use, williamandmary77@gmail.com. And I don't have a website, mostly because as I was kind of working on, the clinical side in 2020, it occurred to me that a website management is a full-time job in of itself. I thought, wait, I want to spend as much time putting things there as I am doing the work. So I haven't established a website, but I welcome folks if they, to contact me that way, and we'll go from there.
Gotcha. And I'll put that in the show notes. Tim, do you want to add anything?
Yes. My website, you can reach me at www.drtimmoss.com, and it kind of gives you an overview of what we've done. And you're also able to purchase the books through that website, in addition to going to Amazon to purchase there. Similar to Bill, my Gmail address is drtimmoss@gmail.com. And so, because part of the goal is being able to get the book in the hands of people that need it most. And we're dealing with family members, the veterans themselves, because the book for the veteran helps them to kind of articulate what they're really feeling. For the family members, it helps them to get a sense of one of my reviewers. In fact, the first draft of the book, I happened to be talking to another veteran that was in the room, and I turned back, and one of the reviews is actually taking screenshots of the draft books, like, oh no, this works right now. My son served in Afghanistan. This is what's going on with him right now. So I kind of chuckled. I said, well, that's the purpose of the book. Nice. You can go in it, and you don't have to start from front to back. If you're dealing with chronic pain that day, you can just flip to the chapter on chronic pain and walk through it. And oftentimes it's very educational, because now it allows you to have the same vernacular and vocabulary that the neurologist has. So now you're able to kind of share with him or her this. I may not be able to say it right, but that word right there on this page, on page 91, is what I'm dealing with. Or, kind of look at this. This was helpful to me. And so, because the goal is to get the information out there, because our veterans, again, they've served at the tip of the spear. They've put their lives on the line. And when folks know that they see my hat or know that I'm a veteran, they will often respond, thanks for your service. And my answer to them, which is what often have grabs my answer back to them, they'll say, thanks for your service, Doc. And I will say, you're worth it. Mm-hmm. And they kind of look at me like, I'm worth it. Yes, that's why we do what we do, because you are worth it. We fight in war because our country, despite some of the challenges, is still, in my mind, the best country on the planet. And the people of this country are worth fighting for. And when a veteran hears that, it helps them to one, be reflective, but it also, it can kind of choke them up in the sense that that's validation that I needed today, that I'm worth you doing the work that you do.
I like that. That's awesome. That is awesome.
Absolutely.
So I've got two last questions I'd like to ask. One is this. As someone who's looked upon, whether as a caregiver, a helper, a healer, how do you make sure that you don't become overcome by the stresses of helping others?
Well, I'll tell you the way I work it is, so I have on my desk, there used to be literally 3 documents. One of them was it looks like a brain drawing, and it's kind of like, how does trauma come up to the amygdala, go through the thalamus and all like that. And one of those kind of ways, just to kind of give a person kind of a map. The other one is the defense pain scale, right? So the defense veteran pain scale is a 0 to 10. It's in color. And the cool thing about it, of all the pain scales, it gives a little descriptor of, when you're 3, your pain is, it's kind of there. It's kind of a naggy thing. When you're at a 5, it's starting to be noticeable. 6, 7, 8, and so on. It gets to the point where you can't avoid it. It's there. You got to do something. And then the other one that I use is called and I hand it out all the time, is the stress continuum model. And the stress continuum model is one of those. It's a little bit like a stoplight chart. But when you're green in relation to stress, and sometimes I'll just intro, everybody has a GPS, right? Well, unless you have an old car or a truck, but you have a GPS, and your GPS is so you kind of know where you are in relation to the rest of the world. Well, in stress, we talk about, well, this much stress, and it can be cognitive, it can be this and that, except the problem is that how do you know where you are with it? So the stress continuum model, I think Patricia Watson and her team came up with it around 2006. I started seeing it, but the cool thing about it is that when you're green, you're good to go. You're ready, right? You've done your training. You're ready to go. Whatever it is your day has out there for you, you're good to go. And if it's just, hey, I go get paid today, okay, no big deal. But when something's going on in your life, whether it's you got a letter from the IRS, or you got to cut the grass and you didn't, your mower broke, things like that. Those are the kind of things that are yellow. There's something that's challenging you, but I got to pay attention to it. And typically there are things that I need to pay attention to, my peers pay attention to, my family, they're going to notice those kind of things. If it continues to build, then I'm orange. And when you're orange, you're certainly different, because now you're irritable, snappy, things like that. I use the expression, if I came in my office and slammed the door, kicked the trash can, start cussing and swearing, hopefully somebody will come to my office and say, Colonel Wall, are you okay? Because I don't normally act that way. And that's one of the ways that we kind of know that something's going on with me. When you're red, that's when you need formal therapy. You're probably diagnosable and things like that. So on that continuum, and it's fluid, right? I can be a certain way at a certain time. And so the thing about the stress continuum and the defense pain scale is it gives kind of a common language. And so here's an example. This past March, April, my wife's sister, who was hospitalized for advanced Alzheimer's, early onset Alzheimer's disease. And Colleen was declining, right? We went to visit the end of March up in Wisconsin, and we had a really good visit. And the visit was good because she recognized us. We didn't have some of the snippy, snappy kind of interactions. We didn't wear her out, so on. So we had a good visit. So clearly at the end of that visit, I'm green. Yeah, I'm good to go. We're driving back. Mary and I are having a super conversation. We get back on a Saturday, Sunday. On that following Wednesday, we get a call from the facility. She's had a fall. Her pupils are now fixed and dilated. She's dying, right? So we pack it up. We pack it up, get our stuff together, and we go up that Saturday. And so now we're basically on a death watch until the 12th of April when she passes away. And so people would ask me, how you doing, right? And I would say, well, I'm yellow today. Right. And I would explain them where I'm at. So it was a common language. Or I'm orange today. This is hurting. I'm feeling like there's nothing we can do. Maybe we should have had her evaluated and all these kind of things. And I'm troubled. I never got red. And I'd ask Mary, how are you? And what color are you? This kind of thing, give a common language. And as things transitioned after she passed and we came back, and friends and family would say, hey, Dad, how you doing? I'd say, well, I'm kind of orange or I'm yellow. I'm doing better. And somebody said, well, what's going on? I said, well, here's an example. after she died, it was as if, the bookcase that's behind me fell over, all my books landed on the ground, and now I got to tip the bookcase back up and put them all back in. That's that idea about how we reassess things after a big loss like that. But it took me a while to go from yellow back to green. And just before I was about to be green, we went to North Carolina, and Mary got sick, right? Big stressor. So I'm back to yellow again. So I use those kind of ways to do that. I've got a back injury. And so like this morning, I came downstairs, Mary said, "How you doing?" And she says, "Well, how's your back?" I said, "I'm about a 3 or a 4." Because it gives if I just said I'm fine, the term for fine in substance abuse is effed up, insecure, neurotic, and externalizing. Yeah, it means everything but that, because people will do that all the time. "How you doing?" "I'm fine." And you're not fine by any stretch. So I use those two, the stress continuum model and the defense pain scale. Sometimes I'll say, "Hey, do you know the pain scale?" Most people have seen them in a doctor's office, just as a way to communicate, to use a common language in regard to not only pain, but also stress, because it changes over time. And I think that, for me, it's, people understand, and if I said something like that, that works. I gave another example. A fellow that Tim saw came to see me, and my defense pain scale's on the desk. And while it's a physical pain scale, sometimes I'll trip folks up and say, "Well, if this were an emotional pain scale, where would you be?" And so he was telling me about his pain, because I knew he had surgery. And he says, "I'm about a 5, maybe a 4. I'm doing pretty good." And I said, "Well, I haven't seen you in a while. How are you doing emotionally?" He said, "Well, I'm actually like a 9. I said, "Oh," I said, "What's the 9 about?" And he said that a very close friend of his had committed suicide about a month earlier. And that opened the door for that kind of conversation. So those kind of things I use them just as tools, but also as ways to communicate language and open the door for maybe sometimes other conversations.
Appreciate it. It's something that, I think a lot of people don't think about, but it's interesting to hear how we deal with what we do.
Here's what mine looks like.
Nice.
I haven't had one in.
Colorful.
If I have a pain scale.
So Tim, how about you?
Can you ask the question again?
Basically, the idea is that you're asked to be a caregiver or a helper or a healer. I mean, that's part of your role, and it's helping people address the challenges they have. How do you take care of you? Because after helping people like that, at some point it has a way of creeping in the caregiver or the helper's world. And so I was wondering how you protect yourself.
Well, there's a great book that's out there called "When Helping You is Hurting Me." And oftentimes the veteran, if you're the caregiver, they want you to go to work and make the bacon and come home and take care of folks. And I use the approach. I do a lot of lectures around staff development. So I always use the phrase, and we had some challenges in the VA system because I did the same lecture. And I said, we focus on take care of the customer. The customer's always right. But my philosophy, I flipped this on his head and said, take care of the staff, because it is the staff that take care of the client. And so it's, as I share with a mom, you have to be able to take care of you. So if you're constantly feeding the kids, you're going to be malnourished, and you're going to be, deprived of the essential nutrients you need to sustain you. So as they say on an airplane, if we have a reduced oxygen, put your mask on first, and then put the mask on your children or those that are acting like children. And so self-care is critically important for me. I do a master fitness trainer, so I do a lot of exercise. I attend to my issues, and similar to Bill, kind of look at the pain scale. I've kind of, for me, I use it on a 1 to 5 scale. So I know at 5, I'm no good to anyone. So I've got to take time to, I enjoy jazz music. So usually when I'm either writing or when I'm on the road, I'm listening to jazz music. That gets me in the frame of mode that helps me to look at creative thought, the improvisation. What do I do to get me back from the 5 back to the 1, or from the red to the orange back to the green? And being aware of that, because one, that as a wounded healer, I can only be as effective with you to the degree I take care of myself. Mm-hmm. In a society that really promotes taking care of other people. And certainly in Christian circles, the issue is the biblical mandate is to love your neighbor as you love yourself, not more than, which is like narcissism, or less than, which is where we get these self-martyrs. I'm going to love myself less than, but equal to. So that means I've got to, be a role model of what I'm practicing, what I'm preaching, but also be attuned enough to myself that if I need time, if I'm dealing with loss in my own family, to take the time. And so for me, I think that's kind of how I live my life in terms of being kind of checking in with myself, and then make sure that I'm there for others as well. But definitely attending to those issues and being, as Bill said, to be able to articulate that. Today's not probably the best day for me to be at the top of where I'm at the top of my game. So let me take time to process, where am I at today and what's really going on either consciously or subconsciously, and kind of use that perspective to address it.
Gotcha. Thank you. This has been awesome.
Can I add something?
Sure.
So Tim made a comment about staff, which reminded me of, one of the other things that I think we do, and it happens in clinical work. I think we probably borrowed it from education or academia, but it's that whole idea about reflective practice. And one of the things that we would do in our staff meetings, and I still do it, in reflective practice, we just kind of review, despite how difficult the week might have been, you could do it daily, but, weekly seemed to work, and was really just kind of openly, just kind of either self-talk, have a discussion with yourself at the end of the day. And the questions are, what do you like about what you've done today, right? What do I like about what I've done today with others, or with myself, or with my garden? It doesn't matter. But what do I like about what I've done? And then the other question is, if I had it to do over again, what would I do different? Not what did I do wrong, but what would I do different? Because that's a chance to go, oh, well, and then if you get it to do another time, you get to do that. And then we hear a lot about gratitude moments, but I'll tell you, if we stay on the line till it's till 23 after 1, you're going to hear my watch go off because I have a setting on my watch at 1, 2, 3. And it's just because it should be easy as 1, 2, 3. And that's my daily gratitude moment, where when my watch goes off, I want to think of 3 things that I have gratitude for. And it's quick. What's funny is that patients that I have or people that I see regularly, my watch will go off and they'll, do you need to call somebody? Nope. And I just do it quietly, but they'll want to participate. And I'll just say, well, tell me 3 things that you appreciate or you have gratitude for. And it's just one of those fun kind of things. But what I know is that for me, and probably for others, if by scheduling it, my watch beeps, it reminds me to do it, and I do it and I have fun with it. Others hear it and they'll say, what's that? And I'll say, it's a gratitude moment. What do you have gratitude for? Helps me stay grounded and focused and on track of what I need to do, and let some of the stress about the kind of things that, I get from the people that I work with just kind of fall away. It's theirs, not mine. It's like they say early in therapy, as a trainer, keep the distress with the client. Well, it's easier said than done. But it's also appreciating, appreciating, what I have versus, what I don't have. So I think the idea about reflective practice is a really kind of strong measure and some level of daily gratitude check.
That's excellent. That's excellent. I like that, especially that you remind yourself to have the gratitude. I like that. Nice.
So today it's going to be Steve Miletto, Tim Moss, and Mary.
Nice. I like that. Very cool. Very cool. Nice. All right. Last question. I like to ask my guests this. Do you have a teacher in your past who made a difference in your life? If so, who was it? And what would you say if you were given a chance to say thank you?
Well, Steve, you're going to love this because you will actually know, as a product of the East Lawrence High school system. I had a teacher in the 7th grade whose name was Deborah Bush. And she was very inspirational in my life. She, I guess, is probably, in my mind, the first person that really saw my true potential when I didn't see it in myself. And she was very good about making that known to me, is that I see the part you try to hide, in terms of just the academic piece, in terms of the insight piece. And she kind of pushed that. And so when I wrote my first book, Horace set something up in Dublin where I went and did a lecture at East Lawrence. I did something for Dublin Junior and Dublin High School. And I just happened to be, and I used the same format. And so I'm at East Lawrence. I'm thinking Deborah is retired at this point. So I make this comment about, there's a teacher that was so pivotal and very powerful in my life that it was palpable. And I said, her name is Deborah Bush. She probably is no longer in the school system. She's probably retired. And she stood up and said, I'm still here.
Nice.
That's cool. So for me, it's kind of, there's a couple that are there. One of them is, her name is Bonnie Wassam. So her name is Bolson now, but she was a English teacher, I want to say in the 8th grade. And her focus on English and literature was just extraordinary. I wrote her a message. She just recently had an 80th birthday. And I wrote her a message, and she had sent back a note that was kind of a scolding note. I gotten in trouble in class because I was slipping a note underneath the wall to my neighbor, kind of a thing. And she remembered that. And so she's one. And it was kind of just the role that English has in terms of literature and writing and speaking, that kind of thing. So there was there. And then fast forward to college. You know, I'm at a meeting with Dr. Saul Feldman and Robert Condon, and they were sociology professors. And they asked me, which I think was kind of a reflective question. And the question was, you know, when you get into mental health practice, one of the most important things you're going to want to do is to put yourself out of business. And I thought, what? You know, why would I want to, what? And they're looking at me kind of like the smile you have on your face. And I said, so what do you mean put myself out of practice? Isn't the whole idea that you get into private practice or some kind of practice and you make a lot of money so you have a good quality of life and things like, and they're looking at me like, he doesn't get it yet, does he? You know, and I'm supposed to be a smart student. And finally it was like, boing, the light went on. And then we had a laugh. And the whole idea was that if you can live a life in such a way that people don't need you in mental health, then you've been successful. And so working with veterans and first responders and teachers and anyone, I don't want money to be in the way. But if there's such a way that we can have an impact so that people don't need us, yay.
That is excellent. Tim and Bill, it was awesome talking with you both. Thank you for writing Complexities and Challenges, Clinical Perspectives in Combat Veteran Treatment and the Unique Needs of Military and Veteran Families. It is a powerful book that shares the challenges associated with returning veterans and methods of addressing what appears in their lives. It is so much needed, and I can't thank you enough. Wishing you the best in all you do.
Thank you so much. Blessings to you too. Thank you.
Thank you.
Hey, you have been listening to Teaching Learning Leading K12, a podcast to help you help kids achieve their dreams. Teaching Learning Leading K12 is a member of the Education Podcast Network. Podcasts for educators, podcasts by educators. Teaching Learning Leading K12 is a member of the podcast network based in Canada called Voice Ed Radio. Voice Ed Radio, your voice is right here. The opinions expressed on Teaching Learning Leading K12 are those of the guests and host. Teaching Learning Leading K12 is intended to share ideas, advice, and suggestions. Teaching Learning Leading K12 is produced for educational purposes. Hey, thanks for listening. It would be awesome if you visited my website at stephenmiletto.com and connected with me, left a review, and listened to more episodes. And by the way, you could also share it with your friends, with your family, and your colleagues. Thanks so much. You're awesome.